So one of the things that was brought up at the meeting was evidence-based medicine. And certainly there's an increasing discussion around evidence-based medicine and how it plays into decisions that we make in our routine practice. Could you describe maybe a little bit about what that EBM means to you and how you use it in your routine practice?
For me, evidence-based medicine means doing the best possible medicine for my patients based on the best possible information I can acquire about that patient, which involves a proper and thorough physical examination and then utilizing medical treatments that have had some reasonable or thorough evaluation and study over time to verify that they are in fact valid therapies. Sometimes we have to base things on our own personal experience, but for the most part I like to try to at least get to first principles and go from there on what makes sense for the anatomy and the physiology and the situation I perceive to be going on.
And I think, I'm quite similar to Dr. Mitchell. For me, the evidence-based medicine and kind of how that plays a role into how I practice is I try to approach each individual case following 3 kind of general guidelines. So first, localizing the lameness as best I can, and hopefully that's through diagnostic analgesia, but sometimes it's through just a really thorough physical lameness exam. I like to then characterize that through some form of imaging, following a discussion with everyone who's on that horse's team, owner, trainer, whoever else is involved, so that we can collectively as a team make a decision on optimizing therapeutics for that horse and what makes the most sense in each situation. And certainly I don't have a scientific paper in my back pocket to support every single clinical decision that I make, but I do try to be as good of a steward as possible for that horse and that situation and kind of everyone involved. So that's what it means to me.
I'm guessing that not all of our viewers have had an opportunity to look at some of the more formal levels of evidence as they're presented around therapeutics, and we'll provide those for people that are interested in looking at it. But what's your back of the napkin version of levels of evidence and how it fits into your practice?
I'll let you go first on
that. Thank you, Dr. Mitchell. I think, for me, I don't have a rigid rule to live by. Like, these are definitely the evidence-based classes. I know that they're out there. I know that there's varying scales of evidence that start anywhere from the highest level of evidence being randomized controlled trials that take place in a very formal experimental situation. And then I know there's considered weaker forms of evidence, like case series or even expert opinions. And I think some veterinarians would say, well, expert opinions should be considered a higher level of evidence, and maybe they should. But I think just as a general rule, knowing that there's a spectrum of evidence that we have for the things that we do, and those things don't always fit into a nice and tiny box and align perfectly with each situation, but having them on your radar, I think, and knowing that they're available, and a good discussion point with owners and trainers and clients. I always preface things that are considered new or novel with, this is the level of evidence that we have to support its use. It may not be very strong, but this is kind of the situation that we're living with. And I think as long as that discussion takes place and everyone, feels good about that, then that's a reasonable place to start.
I think, there are unfortunately not randomized controlled studies for every form of lameness or condition that we see in the horse. We certainly have a great deal of randomized controlled studies for many of the medications and so forth that we have, and that's indeed why we should be using those products that have been in fact proven to be efficacious in specific situations, and not, well, maybe this seems okay or this is a little like that, but if we really don't have good evidence that those products work for a specific condition, it's my opinion that, you know, we have to be very careful about that. Expert opinions are probably the lowest level of randomized, EBM, but you know, I think it is important what your experience has been, because you know, we just don't have the cohort studies and so forth in many situations, and like I said, the randomized controls test studies that they have in human medicine, because we lack the sheer volume. But it should be based on good physiology and a thorough examination.
And wouldn't you say as well, Dr. Mitchell, that sometimes your evidence is that you have a long-standing history with that horse, and
I think that's very important.
You know, your kind of history is repeating itself, and that may not apply to the new horses that you're seeing, but what do you think is kind of the evidence you use in those situations where it's a newer? In the
newer horse, I want to do a thorough physical, and sometimes that is not what I'm asked to do, but I assure my clients that let me have a good look at this horse, and we may elucidate some other issue here that has popped up or that you were not aware of before. I may even be able to save you money by being more direct for managing the condition. So I think it's very important to be as objective as possible in evaluating the horse.
Thanks, guys. I think you really hit on something that I wanted to get your opinion on, and that's that we don't have that many level ones. So the quintessential randomized, double-blinded, placebo-controlled study in equine medicine. So faced with that, should we keep striving for that? How important is it when, you know, it's more and more difficult to get things into the marketplace with the regulatory hurdles that exist, etc.? What should we as an industry be trying to shoot for?
You always let me start with the challenging ones.
Well, I do think that you pose a very challenging question. Not to be evasive, but there are certainly there is a need for safety and controlled studies. There's no doubt in my mind, because I believe that just because a product worked in one situation does not necessarily mean it's always going to be the product that should be used in all similar cases, and especially if there are no studies to evaluate efficacy. I think there are certainly a lot of therapies that we utilize for the sport horse that have no controlled studies and no cohort studies, or just simply the fact that we've done these treatments and we know that they have been effective. However, we are most often using at least medications that have had exhaustive studies and that we know that they have this physiological effect. So we're then applying it to some perhaps new condition for which we don't have that much experience. But it still has to be based on an understanding of how the pharmacology of that product acts and what physiological effects it has.
Yeah, and I would agree with that very much. I think that, you know, to be blunt, I mean, I don't think that trial therapeutics, we'll call them that for lack of a better word, I don't think that trial therapeutics are necessarily wrong to pursue in certain situations, as long as you're following the rules of the sanction and all of that. But as long as everyone's on board with it, you know, the team has that buy-in, and the expectations are laid for what you can expect from that situation, if it's considered to be something new or more of a trial situation. But
the horse can't talk, so we have to try to get the horse to talk to us, and therefore sometimes trial therapies are valuable in that regard if we can achieve a more accurate diagnosis with nerve blocks and imaging and so forth. And sometimes we have no choice but to treat on a provisional basis, but it needs to be narrowed down.
Yeah, and I think we've all been there where we've had a lameness that doesn't block out to a certain spot, and the owner is standing there wanting a very definitive, clear-cut answer, and you can't give it to them. And we've all been there, and I think that's where we start to use that kind of sixth sense as veterinarians to make good clinical decisions on what we do.
So just so our viewers are tracking, when you're using the term trial therapeutics, that would be kind of post, we've done our physical exam, we've done the diagnostics available to us, and we have a working diagnosis, and we're going to use a therapy as a trial to see if there's improvement. Is that how we're using it?
Exactly, yeah. I mean, let's say, for example, a distal limb lameness that blocks to a palmar digital nerve block, and the horse was previously painful to distal limb flexion, resentful of hoof tester pressure over the coffin joint, lamer on hard ground than soft ground. We have a reasonable assurance that it is a palmar foot lameness and that it's likely of coffin joint origin or possibly some form of navicular syndrome or whatever. So to treat that horse provisionally by injecting an anti-inflammatory compound of some sort in its, whether it be biological or a drug, is I don't think it's unreasonable, especially if we've exhausted our imaging capabilities and so forth, or we know the horse well and know that this particular horse has had exactly the same scenario 6 months ago, and we did do exhaustive investigation.
And I think that's a very good example. The horse blocks to a PD, really nothing that significant on imaging. We decide to pursue coffin joint injections because of these other findings and because this is what it's seeming like. But we don't oftentimes have, a specific in the foot, in that black box of an area, we don't have a specific diagnosis. And I think in those situations, it's really important to circle back to the horse's future plan. So we're going to do this today. We're going to start here. We're going to try this. If this doesn't work, this is going to be our next game plan, because it could be a deep visual flexor tendon or collateral ligament or something else that I'm not picking up on today. So I don't think that's a wrong thing to do, as long as there's a good plan moving forward about rechecks and what happens if this doesn't work situation.
There really has to be good communication with the client so that they understand that if we don't get the clinical response we want, or if that clinical response is short-lived, that more advanced imaging and that sort of thing is definitely indicated.
Yeah.
Sherry, Rick, thanks for taking the time to share your thoughts with us.